fact that we are going to be talking about coronary calcium scoring in a little bit of a different way than some of the guidelines have suggested. We're going to ask you to think about using coronary calcium scoring in a way that will provide substantial benefit for your patients. So first, I want to talk about a common clinical scenario that we encounter in our daily patient care activities. The patient comes into you for a primary prevention visit. They've had no previous atherosclerotic cardiovascular disease on a clinical level. And what our guidelines tell us to do is that the first thing we should do is to start with the pooled cohort equations. And this gives us a 10-year risk for the patient sustaining an ASCVD event. And I'm talking about heart events, fatal and non-fatal myocardial infarction, or fatal or non-fatal stroke. Hello, I'm Dr. Carl Oringer. I'm a cardiologist and lipid specialist, and I direct the Preventive Cardiovascular Medicine program at the University of Miami Miller School of Medicine.
And I'm Kevin Mackey. I'm an epidemiologist and lipid specialist, and I'm at the Indiana University School of Public Health, Bloomington.
Dr. Mackey and I are going to be talking about an article that we wrote and is about to be published in the Mayo Clinic's proceedings. The article is entitled "Hope for Rational Statin Allocation for Primary Prevention. A Coronary Artery Calcium Picture is Worth 1,000 Words." So the guidelines tell us to divide these individuals into 4 categories according to what their estimated risk is. Those who are at low risk are considered to be at less than 5% 10-year risk. Those at borderline risk are 5 to 7.4% 10-year risk. Intermediate is considered 7.5 to 19.9% risk, and then high risk is considered to be 20% or greater 10-year risk. So for primary prevention patients with no diabetes and with an LDL cholesterol of 70 to 189, we are then asked to consider how we might approach those patients in terms of preventive care. For those who are at low risk, lifestyle therapy alone seems to be the approach to take. For those who are at high risk, that is 20% or greater 10-year risk, the use of lifestyle plus statin is the way we go. But when you are encountering patients who are in between, and that actually is most of the patients you see, patients who have between a 5% and 19.9% 10-year risk, you then have to make a decision about whether statin therapy should be initiated or whether lifestyle alone is going to be used. And if you have a clinician-patient discussion, and if you decide with your patient that you're going to definitely take one of those tracks, it's fine, the decision's made, and then you move ahead to therapy. But when that decision is uncertain, the guidelines say the first thing you should do is to consider some of these so-called risk-enhancing factors to help you make that decision. These include factors such as a family history of premature ASCVD, primary hypercholesterolemia with an LDL cholesterol of 60 to 189 milligrams per deciliter, the metabolic syndrome, chronic kidney disease, chronic inflammatory states such as psoriasis, rheumatoid arthritis, or HIV/AIDS, history of premature menopause or history of pregnancy-associated hypertension, South Asian ethnicity, or various lipid biomarkers. And the guidelines suggest that when you have a patient who's in that borderline or intermediate risk group, and they are found to have one or more of these risk-enhancing factors, that might help you to tip the scales a little bit more toward the use of a statin. But when the decision is still uncertain, the guidelines say that it is then reasonable to proceed to coronary calcium scoring. And basically, when you do a coronary calcium score, the patients are divided into 3 separate groups in accordance with their score. If the score is 0, meaning there's no detectable coronary calcium, lifestyle alone is felt to be appropriate, except in those with diabetes or who are smokers or have a family history of premature ASCVD. And in those cases, you may want to consider the use of a statin in addition to lifestyle. Those who have calcium scores of 100 or greater actually have a 7.5% or greater 10-year risk of ASCVD, and statin therapy is felt to be warranted in such patients in addition to lifestyle. Now, those who have calcium scores of 1 to 99, especially when it's a patient who is 55 years of age or greater, you might want to consider lifestyle and statin. But if the decision is still uncertain, you and your patient have to decide together whether the addition of a statin makes sense. So that gives you an idea of how the guidelines recommend that we approach patients for primary prevention.
We investigated a theoretical application of coronary calcium scoring to the results from the HOPE-3 trial. HOPE-3 was a primary prevention study in patients at borderline to intermediate 10-year risk for an ASCVD event, and patients were randomly assigned to 10 milligrams a day of rosuvastatin or a placebo, and then they were followed for a median period of about 5.6 years. Now, one of the things that is central is that in patients with a coronary artery calcium score of 0, their 10-year risk is less than 5%. So they can be reclassified into a low-risk category. And among those patients, what you see is that in those with 5 to 19.9% estimated risk using the pooled cohort equations, 40 to 50% are going to have that coronary calcium score of 0. And if you look specifically at the range of 5 to 15% 10-year risk, it's half. And so it's really a coin flip as to whether a person has a high enough risk so that you can be confident that the benefit of statin therapy is going to outweigh the costs and the potential risks of therapy, even though the risks are relatively low. And so when we looked at the number needed to treat based on 44% of subjects in HOPE-3 having a calcium score of 0, which is an estimate based on cohort studies, we see that you have to treat about 206 patients for 5.6 years to prevent one primary outcome ASCVD event. And the number needed to treat with coronary calcium of 1 to 99 was 89. And this group with coronary calcium of 100 or higher, only 50. So 1/4 as many people need to be treated to prevent one event. And I should point out that this is over a period of 5.6 years. And if you extend out the projection to 10 years, it's more like 30 patients who would need to be treated to prevent one event. And so in that group with coronary calcium of 0, you can be confident that their 10-year risk is low, and therefore statin therapy can be deferred. And it might be reasonable in those people to wait another 3 to 10 years, do another coronary artery calcium score to see whether they have developed coronary calcium. Now, in women in particular, we have a recommendation for women at average risk of breast cancer to have screening mammography annually from age 40 to age 54, and then age 55 and older. The recommendation is for either annual mammography or mammography every other year. And so when you think about the radiation exposure associated with a coronary calcium test, it's similar to or even less than that for screening mammography. But some women and their clinicians may be concerned about radiation exposure and not want to have incremental radiation exposure. So for women 55 years of age or older, it might be reasonable to consider substituting one coronary artery calcium test for a screening mammogram. And still, that would allow the woman to have a mammogram every other year. And so you wouldn't be reducing the number of screening mammographies below what is recommended. And so we think that that's a reasonable trade-off, because if we look at a woman's lifetime risk for breast cancer, it's about 12.5%. And so you have an annual test with radiation exposure, albeit low, that is recommended, and it's generally reimbursed by insurance payers. And in contrast, a single coronary artery calcium score is generally not reimbursed, although the cost these days is relatively low, generally under $100 a test. But when we look at a 55-year-old woman's lifetime risk of cardiovascular disease, it's about 50% or more, and lifetime risk of death from cardiovascular disease is about 30%. So in our view, it's a very reasonable trade-off to substitute one coronary artery calcium test for an annual mammogram if the woman is concerned about incremental radiation exposure.
Well, so now we're kind of coming to the bottom line. You got that patient back in your office, you have to make that decision. So you've got your patient, turns out that their risk is somewhere in that 5 to 19.9% 10-year risk. You're not quite sure what to do. You now say, well, if I use the pooled cohort equations, I know that this is population-based, but I might not be giving the patient the right information. Maybe I'll add some of those risk-enhancing factors, but for any given individual patient, it is impossible to say how much a given risk-enhancing factor helps you to reclassify that patient's risk. So in fact, since almost half the patients may have a calcium score of 0 in that group, it makes sense to use coronary calcium scoring whenever possible in those within that 5 to 19.9% 10-year risk group to help you to make rational statin allocation for these patients. You want to be able to treat patients who are going to benefit, and you want to withhold treatment for those who are not likely to benefit or are going to sustain such minor benefit that it's really not to their advantage to be treated. So we hope that as you look at this paper and you think about what we've said, you might want to consider greater use of coronary calcium scoring in those borderline to intermediate risk patients, hopefully to provide better care for your primary prevention patients. Thank you very much for your attention, and we hope you enjoy reading the article.
Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.